Alright, we're going to discuss primary bone tumors, which is not an incredibly high yield topic, but there are a couple that we'll point out as being fairly important. Let's turn our attention first to the primary bone tumors that are benign. There are two tumors here that have very classic presentations. Giant cell tumors are the first high yield tumor in this group. They occur in the epiphyseal end of long bones, so think of the distal femur and the proximal tibia most likely. They commonly occur at 20 to 40 years of age, which is one of the distinguishing characteristics, as most other tumors tend to be in a younger population. They're locally aggressive, and an X-ray will show the double bubble or soap bubble appearance. And histologically, they'll show spindle-shaped cells with multinucleated giant cells. Do you see the multinucleated giant cells? Giant cell tumors express high levels of rank ligand, which does what? It's a ligand that induces formation of the multinucleated osteoclasts. One more classic fact to know about giant cell tumors is that they're more likely to present in women. The next tumor that we'll discuss is slightly lower yield, but has a couple characteristics that should make it easy to recognize if you're asked about it on your boards. Osteochondroma. What does the name indicate that it's composed of? Yeah, bone and cartilage. It is in fact the most common benign bone tumor and is often seen as a piece of mature bone with a cartilage cap in men less than 25 years old. It commonly happens in the metaphysis of bones. It grows out of the bone and presents as an exotosis. This type of tumor can malignantly transform into a chondrosarcoma, but that's pretty rare. And now we'll move to the malignant tumors of bone. These are high-yield tumors that you'll need to be able to recognize for step 1. We mentioned two important malignant neoplasms, but you should also know about multiple myeloma. Multiple myeloma is actually the most common, and due to its relation with B-cell physiology, will be discussed in the hem-onc section. The second most common malignant bone tumor is osteosarcoma. It's also known as osteogenic sarcoma. Who gets osteosarcomas? It mostly occurs again in young males, aged 10 to 20, but there is a second peak above age 65. Like the osteochondromas, osteosarcomas are also found in the metaphysis of long bones. This MRI shows the tumor arising in the metaphysis of the left humerus. So what do you need to know about osteosarcomas? A, what they look like on X-ray, and B, predisposing factors for osteosarcoma. Classically on X-ray, osteosarcomas are described as appearing as a Codman's triangle or as a sunburst pattern. These terms radiographically describe what is happening pathologically in the bone. The tumor cells are growing underneath the periosteum of the bone so fast that the periosteum is being lifted off its normal plane of growth, which creates the triangle, or sunburst, that so classically describes osteosarcomas. The second thing you should remember is why people get osteosarcomas. The list is long but worth remembering, and includes Paget's disease, bone infarcts, radiation, and familial retinoblastoma. Do you remember from the pathology chapter which gene is commonly lost in retinoblastoma that also frequently is lost in osteosarcoma? That's right, RB1. With the first three, you can imagine reasons for the bone to be damaged, and more prone to dysplastic changes as a result. Flash quiz time. What is the classic finding for osteosarcoma on X-ray? Codman's triangle, or sunburst pattern of the bone, which you can see here in the X-ray. The second malignant tumor to know is Ewing sarcoma. This is a type of tumor that's called a small blue cell tumor. This pathology shows sheets of small round blue cells in Homer-right rosettes. Do you recall what other tumors are described as small blue cell tumors? Neuroblastoma, medulloblastoma, retinoblastoma, and Wilms tumor. Like all other tumors in this family, Ewing sarcoma is very aggressive and presents often with early metastasis. Where does it metastasize? the lungs. However, it will respond well to chemotherapy, which is life-saving for patients. It can happen in a variety of bones, usually in the diaphysis of long bones, but also in the pelvis, scapula, or ribs, truly on most parts of the body. There are two classic aspects of this disease to remember. The X-ray catchphrase is onion skin appearance in bone. You can remember this with the catchphrase E-wings and onion rings. And the other important thing to remember is that it occurs as a result of an 1122 chromosome translocation. This results in translocation and fusion of protein EWS-FLI1. There aren't any other malignancies in this section with similar translocation, but in the Hem/Onc chapter you'll see at least 3 more, so be sure to keep this straight. If you follow basketball, 11 plus 22 equals 33, and was Patrick Ewing's jersey number, if that helps you. Where do osteosarcomas originate? In the metaphysis of long bones. Let's move on to joint pathology and talk about osteoarthritis and rheumatoid arthritis. Osteoarthritis is another very common disease, and on the Step 1 exam, common diseases will show up in questions very often. Sometimes they'll give you a presentation that will make you think of another disease, but will not give you that single additional classic feature that gives you a more exotic diagnosis than everyday osteoarthritis. And remember, common diseases present uncommonly frequently, while uncommon diseases present commonly infrequently. Always remember to consider the simple, easy, common diagnosis first, and only go with something more exotic if in fact you're being given a detail that makes you truly confirm it. And always answer the right question at the right time. Okay. Osteoarthritis is a disease that is thought to be mechanical in etiology, with chronic wear and tear of the joints that leads to destruction of articular cartilage. If you were to stain a slice of someone's osteoarthritic joint with safranin O, what would you expect to see? A major decrease in the amount of cartilage, because this stain, safranin O, helps to visualize bone versus cartilage. It's often marked by nodules in the DIP joints and the PIP joints, which are called the Heberden and Bouchard nodes. Try and keep these straight. I always tried to remember them by Heberden's goes with the DIP joints, and I would say to myself, hip dip, using the H to rhyme with DIP. Overall, osteoarthritis is almost exclusively found in older individuals, especially those who are obese, which puts more mechanical strain and stress on the joints. What else could alter the mechanics of a joint? Previous injuries or deformities. What will be the patient's clinical vignette? You're going to hear about an older individual with pain in the weight-bearing joint after repeated use, particularly at the end of the day, and it's going to improve with rest. When it's in the knee, it's usually on the medial aspect of the knee. What else is classic for osteoarthritis? For one, this is a non-inflammatory arthritis. When we speak more about the different inflammatory arthritides, this will be more clear. Because there is no chronic inflammatory undertone to this disease, there are no other systemic symptoms that come along with it. This is very different from chronic inflammatory arthritic diseases, like rheumatoid arthritis. Knowing about the pathology, do you think we would more commonly use steroids to treat osteoarthritis or rheumatoid arthritis? That's right, they're probably going to be more useful in rheumatoid arthritis, in which their anti-inflammatory properties would have a greater effect. So what happens in osteoarthritis? Normally, there's a large joint capsule that travels up the side of the joint. Within this joint capsule, there's a synovium, which provides further protection for the joint. And finally, there's a piece of articular cartilage on each side of the joint, overlying both bony surfaces. In osteoarthritis, normal anatomy can be markedly affected. For one, the capsule can thicken, and the synovium will hypertrophy. The joint space itself will narrow, with ulcerations developing in the articular cartilage surfaces. This can also lead to bone touching directly on bone, leading to sclerosis and bone cyst formation. Finally, osteophytes may form, which can protrude into the joint space or out around the joint space borders. Why do osteophytes grow? In an attempt to stabilize the joint. The end product of osteoarthritis is a completely fused bony joint. You will most likely see a patient with knee disease and narrowing of only the medial compartment of the knee, which you can see on this x-ray. What's the first step for treatment? Weight loss and exercise. You can move to NSAIDs and glucocorticoids for non-responsive or severe pain. Last resort treatment is a knee replacement. Okay, in contrast to non-inflammatory diseases like OA, rheumatoid arthritis is the first of a few inflammatory arthritides that we'll discuss. What makes rheumatoid arthritis different from osteoarthritis? Rheumatoid arthritis is an autoimmune arthritis affecting synovial joints with formation of a pannus in the joint. Pannus basically just means an overhanging flap of tissue. Clinically, as with many autoimmune diseases, which gender do you think is more likely to get rheumatoid arthritis? That's right. Women are much more likely to present with rheumatoid arthritis than men, and it's often in younger women. Also, as with most autoimmune diseases, it's important to know some of the key immunologic properties that distinguish this disease from other autoimmune diseases. For one, it is marked by type 3 hypersensitivity, which you'll remember from the immuno lecture as antibody complex mediated. The classic antibody is aptly called rheumatoid factor, or RF, which is actually an antibody that develops against the Fc portion of IgG. However, only 80% of the people with this disease actually are positive for rheumatoid factor. So while it's important to know, it is not necessary to make the diagnosis. There's another antibody called the anti-CCP antibody, or cyclic citrullonated products. These CCP molecules are thought to be involved in the inflammation that happens in the joints of people with rheumatoid arthritis. While the anti-CCP antibody is less common, thereby making it a less sensitive indicator, it is also more specific, meaning if it's positive, you are much more likely to truly have rheumatoid arthritis. Also, there's a segment of the HLA molecule, DR4, that's associated with rheumatoid arthritis. So how will your patient on the boards present? She will likely describe morning stiffness for more than 30 minutes that improves slowly with use or by running her hands under warm water, or even perhaps after a warm shower. Patients with osteoarthritis will have morning stiffness as well, as a result of not moving all night while asleep, but it often resolves in less than 30 minutes. Which disease improves with rest? Osteoarthritis, not rheumatoid arthritis. Also, the disease tends to be symmetric. So, if certain joints in the hand are affected, and then the same joints on the opposite hand tend to be affected, then you have rheumatoid arthritis. What else should you look for when you're thinking rheumatoid arthritis? Systemic symptoms. Systemic signs will include fevers and fatigue, weight loss, but can be more subtle with pleuritic chest pain, which would represent underlying pleuritis, or even vague chest pain that could indicate pericarditis. Just to double check, do you know what we mean when we say pleuritic chest pain? If you said chest pain that hurts when you breathe, then you're right. Use these differences to choose between the two on step 1 questions. First-line treatment of rheumatoid arthritis involves use of NSAIDs to decrease inflammation. Selective COX-2 inhibitors, such as celecoxib, are also frequently prescribed, especially if the patient has a history of GI issues with NSAID use. Glucocorticoids and other drugs which modulate the immune response may also be taken by these patients. DMARDs are the classic treatment for rheumatoid arthritis, and if you see a TNF-alpha inhibitor such as etanercept or infliximab, it's likely going to be the right answer. Let's take a closer look at the joints involved in rheumatoid arthritis. Here, we see increased synovial fluid and pannus formation. The key here is that the joint is being degraded, instead of forming osteophytes and filling the joint space as seen in osteoarthritis. Clinically, the physical exam and radiographic findings can be very telling for RA. What would you look for on exam? You may see subcutaneous nodules, which would appear like small bumps, often not incredibly large, but usually multiple or apparent. These rheumatoid nodules don't only have to be in the skin, but also could be in the lungs or other viscera. So if you're hearing about joint pain in the vignette and see a chest x-ray with bilateral hilar fluffies, consider rheumatoid arthritis as the answer. Examine the joints themselves should focus on the hands, particularly looking out for ulnar deviation and subluxation of the finger joints. As you may imagine, chronic inflammation within the fingers will lead to many frank deformities of the joints, such as boutonniere deformity seen in these hands. Within the fingers themselves, MCP and PIP joints are most often affected, but characteristically the DIP joint is not involved, in contrast to osteoarthritis. Alright, flash quiz. Which joints of the hand do Heberden nodules affect? The DIP. Remember, do the hip dip, where H is for Heberden. Osteoarthritis presents with stiffness at what time of the day? Usually later in the day, after exercise. Which disease is more likely the result of, instead of results in, deformity of the joint? Osteoarthritis or rheumatoid arthritis? Osteoarthritis is the right answer. So let me ask you, which would you rather, OA or RA? If it were up to me, I'd definitely choose OA. OA is a mechanical problem and can be fixed mechanically in most cases, with joint replacements. RA, on the other hand, requires a complex regimen of medications with some pretty nasty side effects. It also comes with a whole package of autoimmune disorders.